that it goes to the different fraternities and it's not being diagnosed, what is the basic disease is. And the syndromes, when you manage or diagnose syndromes, the most important thing is to keep your minds open. I'm a self-studied syndrome specialist because I didn't have a formal training about syndromes. This morphology. This morphology is a subject. Smith's recognizable syndromes at a boro boi ache. The human mind is like a parachute. It only works when it's open. And I have seen many a times that it has gone to the cardiologist. The cardiologist has seen the heart and didn't diagnose what's the original disease. I will show you some cases. Now, when should you worry about a short stature? The less than third centile in the country-specific growth chart, downward crossing of 2 percentile lines, growth velocity. Huh? সেটা তো বলছি ছাড়ো জুমটা ছেড়ে দাও 22 জন পার্টিসিপেট আছে So, when should you worry about short stature? It's less than third centile in the country-specific growth chart. So, not slide change hoche na keno? আর এটা ছাড়ো না তুমি বুঝছো কেন আগে এটা ছাড়ো না ফুল স্ক্রিন হচ্ছে না এইটা তো চালানো আছে বন্ধ করো ঠিক আছে তাহলে এটা এরকমই থাকবে এটা কি করবো ঠিক আছে So, when do you worry? Less than third centile in the country-specific growth chart, downward crossing of the 2 percentile lines, and growth velocity less than 25 centile over a minimum period of 6 months or 12 months, and height more than 1.5 centimeters standard deviation below the mid-parentile height. See, the causes of short stature mostly are constitutional delay in growth and puberty, and familial short stature. As you can see, 45% and 50%. And the rest are much less, like systemic disease, panhypopituitarism, growth hormone deficiency, hypothyroidism, idiopathic short stature, rickets, skeletal dysplasias. They are much less. Now, most important investigation that you need to do about the short stature is the bone age. And how can you assess the bone age? One is Greenwich and pile charts that we used to use, but after Hidayah has come, we are using more computerized ones. Tanner Whitehouse 3 is now going on. That's more accurate, but it's very, very cumbersome. Gilans and Rativ one and computerized one. Now, bone age is not useful exact etiology. It will not give you exact etiology. Is the bone age same as chronological age? Is the familial short stature? Bone age significantly delayed is either endocrine or hypothyroid or growth hormone deficiency. But if you find that the bone age is mild delay, think of chronic constitutional delay in growth and puberty or chronic illness. But bone age may be advanced in short stature, that is ACAN gene or IHH, Indian hedgehog gene. These are the two conditions where you will have the short stature, but the bone age will be advanced. Now, ACAN mutations causes familial short stature. I'm yet to see an ACAN mutation. The short stature, majority are normal variant, but pathological in 10%, and of the 10%, with dysmorphism and abnormal proportion. And this is the area that I'll be discussing today about the dysmorphism and abnormal proportion. See, abnormal proportions is the short limb or short trunk or short limb and trunk. And syndromic short stature is associated with congenital heart disease or skin abnormalities or limb defects. I will show you the cases afterwards. There are many causes of syndrome with very short stature. I've seen most of them, but Mulberry syndrome I am yet to see, or Jonason-Blizzard syndrome I am yet to see. And syndrome with moderate short stature, Robino syndrome and floating harbor syndrome I am yet to see. Should an endocrine criminologist learn about this morphology? Yes, because many times you might get a bouncer right in the beginning. And this is the bouncer case we have shown you many a times. I'm not going into the details of that. That's the rapid onset of obesity. Each and every term plays a role. Now, when I was asked to see this child, my residents told me this child has a rapid onset developed obesity. So the moment I heard that rapid onset weight gain, so that gave me the clue that it might be a Rohat-Net syndrome, and it turned out to be a Rohat-Net syndrome. And when we see the X-ray, there is something here, and that was initially was thought of as pneumonia, but it's a neuroendocrine tumor. We did the MRI brain, it was not contributory, but when we did the MRI of the thorax, that showed the mass, and the mass was taken out, and it was a quite big mass, and it showed that it is a neuroblastoma group. And this is Rohat-Net syndrome, a lot of features can be there. The next important, I mean, not important, but it is important to me because I worked this with this person, Dr. S.P. Ghoshal, who was president of Indian Academy of Pediatrics in 1980. And I think after 43 years, we'll have another president, and I pray and request everybody to vote for Dr. Joydeep Chaudhary so that we can have the next president after 43 years. No. This man was really dynamic. I have seen him working for this syndrome. I mean, tons of papers he wrote, and he ultimately published this, that this is a Ghoshal hematodiaphyseal syndrome. When he was trying to publish, everyone said that no, this is not a separate syndrome. This is an Angelman-Camurati syndrome. But he disagreed with that, and ultimately Journal of Pediatrics published in 1988 and was taken by the Oxford Medical Database as a different disease. Now, before going to this, you must have a rough idea about this. That is a normal one. But when you see that it's an epiphyseal disorder, you will see that the epiphysis is dysplastic. This is very difficult. Below the epiphysis is the metaphysis, and metaphyseal dysplasias are very difficult uh, to diagnose sometimes. And this is diaphyseal disorder, that is Ghoshal hematodiaphyseal. You see the bones, which is quite thick. And this is the Ghoshal hematodiaphyseal syndrome in Oxford Medical Database. I was included in the paper. The only reason is that I found out this man, Mukesh, from Malik Bazaar market after a lot of efforts. And this is the case that I diagnosed in my clinic, which is a Ghoshal diaphyseal syndrome, and responded very well to steroid. And this is the latest case. And this case actually was diagnosed in a reverse way. This child had anemia. Only a few days back, this child had anemia, and they didn't do any X-ray, and they did a genetic study, and the genetic study showed that there is a Ghoshal hematodiaphyseal syndrome. And after that genetic diagnosis, we did the X-ray in our hospital, and you see that the bones are thick. This is a very young age, so fluid changes will be seen afterwards. And this is the gene that has been diagnosed, and in this case also, this has been diagnosed as TBXAS1 gene, and which is on chromosome 7, which is one of the notorious chromosomes that you can have. I think this case was brought to me by Priyankar in a very early age to my clinic, and they came from Bihar. And looking at the child, I said that this is a progeria case, and that was my second progeria case. And then we found out the family, sending Birendra Rai and Chandan Chattopadhyay in Bihar, and we found out the family. And you can see that the clavicle is absent and dysplastic. And that is very characteristic of progeria syndrome. And this is the gene that we have found out, laminaceae gene, which is a autosomal recessive. Because in the books, you will find that this is an autosomal dominant also. And Priyankar Pal. Priyankar, is it your first paper? In 2004, when it was published?
Almost, yes.
Yes, it is. It's your first paper. And I was lucky internationally, no, not even nationally also. It is the first international paper. And I was lucky to be a co-author with Priyankar Pal in this case. Now, I always say I am short. You are tall, who is best of all. And you will see the Sachin Tendulkar is short, but he's the best. Now, this man was 4 feet 9 inches. And what you see here, he had a stick, and that stick was full of alcohol. He was an alcoholic. He had multiple fractures, and he was born in 1864 and died in 36 years, 1901. And Tolstoy-Lortek syndrome, he was a fantastic artist. He was a fantastic artist. No one wanted to marry him, so he used to go to the prostitutes' quarter and used to drink alcohol, and he died at a very early age, and because of the fractures he had. And believe me, this man drew this picture, and this is the highest in the world, the longest that he has drawn, with 164 crores. This is really, really a fantastic painting. And that's the highest in the world to have these pictures being sold in the auction. And as you can see in this child, there is a crowding of the teeth. The eyes are slanting down. There is increased bone fragility. That one happens in Lortek syndrome. Increased bone fragility. This child came to our outpatient, and the short terminal phalanges, the wide open fontanelle, and what you see that the clavicles in the lateral part are dysplastic and broken like. That's again very characteristic, and that type of clavicle you get it in cleidocranial dysostosis, pycnodysostoses, and progeria. I've shown you that the clavicle is absent in progeria. And look at this supraacetabular constriction And this is a normal, and there is no constriction here. And this is a spool-shaped, spool-shaped vertebra, which is very characteristic. Bones are like marble bone disease-like. And the reason I have shown you this picture, the training in UK. So this is a 100 pediatric picture test, and they expect you to diagnose this disease in your MRCP exam. And this is 300 pediatric picture test, and that book contains. So the training is more complete there. We learn a lot about cerebral palsy mechanisms and others, but we need to have a wide knowledge in pediatrics. And this is pycnodysostosис, and see how nicely Sukanto has described this disease and has diagnosed pycnodysostosис. Now, this child at 10 months of age came to me with some other problem. And when I saw the child, the head was slightly big, and I did a X-ray skull, and I did a X-ray skull to show that there are plenty of Warmian bones. The diagnosis is in the chest X-ray, and you see that the chest X-ray, there is no clavicle. And this is the same child at the age of 14 years on follow-up, and see there is cleidocranial dysostosis, which is a RUNX2 gene on chromosome 6. And this is the child at the age of 14 years, so there is no clavicle in this child. This child was came to us a couple of months back with a diagnosis of rickets. And see the look at the vertebra. You don't get this type of vertebra in anterior tongue-shaped projection. And you see the metaphyseal. This is the metaphysis, and you see the metaphyseal changes in the bones. And so it's a spondylo. This is a spondylometaphyseal dysplasia of Kozlowski type. And look at these, the metaphysis, they are all difficult. So the same thing again, that the metaphysis is involved, and this is a spondylometaphyseal. And look at this report by Dr. Debashish Mukherjee, spondylometaphyseal. Though in the gene study, it said that multiple epiphyseal dysplasia. So genetic studies sometimes can be a little confusing, but you need to have a clinical correlation along with this. Why should an ophthalmologist learn about this morphology? See, this child went to Hyderabad, and there for blindness, sudden onset of blindness. And it has an autosomal recessive mutation. And look at this chest, which is very small. And the thoracic dystrophy or asphyxic thoracic dystrophy or June syndrome was not diagnosed in this case till they came to our hospital. And this is the X-ray of this. I was a little surprised that why should the thoracic dystrophy should present with blindness. And on searching, I found, see, look at these bones. And on searching, visual loss as the presenting sign of June syndrome. The beauty and advantages that we get nowadays after this internet, that I could find out that it can present as June syndrome. And this is my first case of June syndrome. And look at this spine, which is very characteristic of spinous projections that you can have in June syndrome. And June syndrome and this case, chondroectodermal dysplasia. Why chondro? See the shortening and these ectodermal changes that you can have. Even the teeth are very narrow and conical teeth. And this case, Hridoy diagnosed only few days back with because Sukanto has shown a case of chondroectodermal dysplasia, just I shown you. And this has Ellis Van Peeble syndrome, EVC1 and EVC2. When Ellis and Van Peeble, they were traveling to a conference, and they met in the train, and they were describing. And so both of them published this case, Ellis Van Peeble syndrome. And interesting in this case is the short fibula. And this is the X-ray that we have done here. And look at this fibula, which is short in Ellis Van Creveld syndrome. And the tooth are very characteristic. They have a post-axial polydactyly in this case. And this is the hip. The hip changes are not very marked, but this is the hip changes. And the hip changes of Ellis Van Creveld syndrome and Jones syndrome are very characteristic, similar. And this is one of the cases that I had diagnosed about 20 years back during the newborn period. Look at these hypoplastic nails that you can have. So when you have a short limb dwarfism or short stature, you can have a rhizomelic, you can have a mesomelic, and you can have acromelic. The acromelic short stature that I have shown you now. Mesomelic, I'm yet to get a picture of mesomelic of my own. Now this case came to my outpatient brought by one of these juniors, and what I found is that he has a very sparse hair and was short. Correct. See, this immediately clicked in my mind, the cartilage hair hypoplasia. And this child is cartilage hair hypoplasia. And what you see here is that they are in chromosome 9, but they can have a immunodeficiency syndrome. So the chickenpox infection is very common in this case and can be devastating. And in Amish population, it is 1 in 1,200, but on the whole, in the world, it is 1 in 23,000. Now, there are genetic syndromes where it can be associated with immunodeficiency, and Ritaboto's latest craze is immunodeficiency, and Dijot syndrome, Kabuki syndrome, and cartilage hair hypoplasia. These are common that you see other than what is written there. And this is another case of cartilage hair hypoplasia brought by one of our senior register from Arjikar Medical College, which was not diagnosed there, and cartilage hair hypoplasia as the diagnosis. This is patla, and this is obvious. You know the Harler syndrome and Hunter syndrome, but the reason I'm showing you this is that the anterior lower tongue-shaped projection in the vertebra is very characteristic. And there are a lot of syndromes from 1 to 8, and then Dipanjana, come here, over 1 to 8, and then now MPS like is the latest one being added. And I remember, you know all about, but for postgraduate, if there is an N in the syndrome, then it is the neurological feature, that is Sanfilippo. And if there is no N, like Morchio or Marotex Lamy, they will not have neurological features. So N is neurological, that's Sanfilippo, they will have mental retardation. Harler and Hunter, that he was it? No. I'm not talking. See, Hunter and Harler, you know. It's no point. It's no point discussing on this. It's only when the multiple choice questions that Sanfilippo and Hunter to ache, kintu Hunter neurological ache. Hunter neurological. Hunter is neurological. Harler is neurological. When you are confused between Marotex Lamy and Sanfilippo, Sanfilippo will have neurological features. Plus Hunter to thake. Hunter the neurological features thake. So this is the only case of Hunter syndrome. See, when this child came to me, I diagnosed at this stage, it was a little difficult. Now, what was characteristic is little bit of clawing of the hand. And then I did the X-ray. The X-ray showed the features. I'm not going into the details. The pelvis is very characteristic. The lower lateral epiphyseal center is dysplastic. So the pelvis becomes like a iliac bones, like a fan-shaped one. And this is the follow-up of this child. He is now around 19 years, now 20 years. And he is on Elaprase. We did the urine gag, it was positive. We did the serum iduronate 2 sulfatase, it was low. We did the genetic study, it was low. This is the genetic study. And he's on Elaprase. This is the only one patient here. And the other patient that I am borderly is managing in
Yes.
EDF hospital, because the child is more than 17 years old. And believe me, this child that who is getting elapraise was seen in Delhi also. But the moment they came to me, I said, this is Hunter syndrome. But because there was no corneal clouding in this child, and hunter will not have corneal clouding because a hunter should not be blind. So that's how we remember. And they can have white matter changes because by the time that I started elapraise, there was some white matter changes in the brain. This is a Morphew syndrome, and Morphew mainly fatty spondyly is the feature of Morphew syndrome. It's in the YouTube. We don't need to take the pictures. It's in the YouTube. And the Morphew, you see that the ribs are there, which is very characteristic. And look at the spine, which is the fatty spondyly. Now, many of me, at least especially, are confused about coxa valga and coxa vera in the hip. When the hip from the midline, it's coxa valga. And look at this pelvis, it's a coxa valga. It's the angle is more than 135 degrees. When it is like this, it will be coxa vera. But the normal angle is around 130 degree. So that's the coxa valga. In most of these cases, you will get the coxa valga cases. And see at this is a coxa valga. This is very rare, which looks like hurler hunter, but at a very early age, presented within a few months of life. And when you see a very hurler-like changes in the very below 1 year of age, don't think of mucopolysaccharidosis, think of mucolipidosis, and see the changes in the bones which has developed so early. This was in 2002 that I have diagnosed. This is very interesting and has a painful story behind that the first case of this Swart-Champel syndrome, which I diagnosed, who was a student of our Nivedita school. I diagnosed that this is the Swart-Champel syndrome, but only one mistake I did is that I didn't tell them not to have a cold water swimming. And what happened in this child? They went to village, had a swimming in the January, and had the myotonia and was drowned. So this advice should be given, and see myotonia with sad fixed like faces. So the gene is HSPG2. Now, I was fortunate to have Dipanjana with us, and then I sent this case to Dipanjana. Dipanjana, what do you think? And then she said yes. And then we used the phase 2 gene, and the phase 2 gene showed with the face that it's a Swart-Champel syndrome. That was the most probable in this case. So the phase 2 gene has really helped us in diagnosing the syndrome. Turner, you all know, but the reason I'm showing you is this: if you have a webbing of the neck, expect that there will be some cardiac problems. And as I showed you this, 11-fold higher chances. And this is Turner syndrome. I'm not going to this. But one of the most interesting that if a Turner inherits the gene from the father or the mother, does it matter really? Yes, it matters. When it is inherited from the father, they are better adjusted, like most of the males. They are superior verbal, which is wrong. Females are much superior verbal and higher order executive function skill. And this has been studied in many cases. And they can have a pectus excavatum and carinatum combination, means initially part pectus carinatum and then excavatum. But this is also characteristic of Noonan syndrome. You see the short third and fourth metacarpals in these cases. And Noonan syndrome used to say that it is like this, but PTPN11 gene and it's on chromosome 12. So 11 and 12. But remember that the von Willebrand factor is in chromosome 12. And if you have Noonan syndrome, they can have more chances of bleeding disorders. So be careful about this. This is the male and female Noonan, and this is the Noonan which has a big scar. Now, Noonan has a pulmonary stenosis. Why should there be a scar? it can be done the balloon valvoplasty, but no, the Noonan syndrome, they have the this plastic valve. So it cannot be, if you look at this, and early in life features are more marked. And this child was diagnosed as pulmonary stenosis, and they came to me. I thought it's Noonan, so I referred to Dipanjana and Dr. Bornali Ghosh, and they had the heart. The RAS MAP kinase pathway, there are a lot of disease in this: Legia syndrome, cardiofasciocutaneous, neurofibromatosis type 1. So they are all of the similar group. And this case was brought to me by Pratiksha, and with a lot of lentigens, I said that look at the heart, and that heart had the pulmonary stenosis. We did the genetic study, and that showed the Leopard syndrome. Though I don't like the term of Leopard, but it's again, it found out to be a PTPN11 mutation. And this is my first case of Leopard syndrome, where multiple genosis. And what you see here is as a hearing aid. And that is a feature of Leopard syndrome, that deafness in 20% of the cases and multiple gens. Any diagnosis? Cornelia-de-Lange syndrome. So this is the Cornelia-de-Lange syndrome. And again, this is characteristic phocomelia in Cornelia-de-Lange. Their umbilicus is very characteristic, as if someone has done the operation on that, or the type of level that we see after we did the exchange transmission. And this is another Cornelia-de-Lange. This is a hitchhiker's thumb. You get it in diastrophic dysplasia, but also Rubinstein-Tyaby syndrome, a chromosome 16 defect. And this is Hriday's favorite case, Russell-Silver syndrome, and very characteristic clinodactyly that you had with slightly largish head. And this child is a genetically proved Russell-Silver. But what confused me is that both Russell-Silver and Beckwith-Wedman, they are in the same gene of chromosome 11, though 10% of the cases may be in chromosome 7. And Dipanjana explained to me why it can be with a large and with a small. I cannot tell you, I cannot recollect. And see, this child was getting thyroid medications for quite a long time before they came to my outpatient. And what they, because no one looked at this part, that these pits behind the ear are very, very characteristic of Beckwith-Wedman syndrome. And this is obvious, very characteristic in our institute. But too much syndrome-minded doctors can miss treatable disease too. I mean, this child was referred to me by Dr. Devashish Mukherjee, and I was thinking that it is a Russell-Silver syndrome. But in the process of sponsoring some people, I did an MRI, and the MRI showed that there is hydrocephalus. Thank you, Dipankar. Seckles barred-headed dwarfism, very old case in 2000. Seckles barred-headed dwarfism, again, the term should not be used. And this is another case of Seckles barred-headed dwarfism I diagnosed in 2000 when I went to NRS Medical College to take the exam. And this is an NRS Medical College page. Why should an infectious disease specialist learn about dysmorphology? See, this child came to me with fever for a prolonged period of time, but not at all toxic. So I say that this child has a hypothalamic problem. And so you get this child admitted in a AC room, and they admitted in Neotia, and the fever was not there. One of the senior pediatricians came and she said, "Aisa hoi nahi sakta." I said, "Yes, it is. I'm not showing the eyes of this child because he has a very light colored eyes. And look at the growth chart. This is very characteristic. The look at the growth chart, and then this patient was diagnosed here, and with the intervention, it came down. And the same, another child, look at this growth chart, and this is the importance of having a growth chart. And this is a female child, And look at the fish study that we did, and it's in chromosome 15, it's a Prader-Willi syndrome. Both the cases are Prader-Willi syndrome. Now, how do you diagnose Prader-Willi? It's methylation. In 99% cases, you'll be able to diagnose the methylation study. But if you want to know why it has happened, then you need to do this fish microsatellite analysis or imprinting center analysis after you have diagnosed. This is a new, relatively new hyperphagic psychosocial short stature, a clinical review. This is more used in UK, but not in America. And this child, again, a chromosome 15 disorder, but with seizure. Look at this child whose parents are like normal Bengali, but it's an Angelman syndrome. Again, a light color. Because in the chromosome 15, this is the tyrosine system and the pigmentation is there. Why should a pediatric cardiologist, again, this is a Kabuki syndrome. They diagnosed, but it was not diagnosed as Kabuki syndrome. This is the Kabuki syndrome, again, another one. And these are the case where they have done the operation, but the George check was not there. And this is again a DGeorge syndrome. This is again a tubular nose. This nose is very tubular, and that's very characteristic of tubular. And this is a cardiovascular disease with supravalvular aortic stenosis. Which one? Williams syndrome. This is a Williams. This is a Williams. This is a Williams and genetically proved Williams. Costello syndrome is another one. And Arscock syndrome. Look at this Schall's scrotum. This skin above this penis is very characteristic, along with the webbing of the fingers are in Costello syndrome. You know this, the Treacher Collins syndrome. This is another Treacher Collins. And this is very interesting, is Hall-Pallister syndrome. Short stature with polydactyly, and you do the MRI and you see that there is a hypothalamic hematoma. And hypothalamic hematoma, 5% of them may be Hall-Pallister syndrome. This child, we had a repeat MRI on a few days back, and night blindness, retinal dystrophy, mental retardation, and polydactyly. This is Bardet-Biedl syndrome. This is the twin, both the brothers with Bardet-Biedl syndrome. And this is a very, very rare condition, Bardet-Biedl syndrome or lipodystrophy. Look at the lipodystrophy. The triglyceride is very high. This is another one. Hidayah is now managing this case. 1 in 10 million people. Initially, so Bardet-Biedl syndrome. There are two treatments now: metrolaptine and metformin. But we are using metformin only in this case. This child went to South, and without a diagnosis, they came back. Only thing they did is that they have taken away the CT scan, because the CT scan showed basal ganglia calcification. And when the child came to me, there was skin erosions as if like xeroderma pigmentosa. I thought it is Williams syndrome, I mean Cockayne syndrome, and it's a mitochondriopathy. And it's not progeria. Cockayne, Bloom, Rothman, Thompson, and xeroderma pigmentosa. When you did the endoscopy, they say that it's a salt and pepper retinopathy. And that's very characteristic of Cockayne syndrome. We did the MRI, and this is obvious, you know, that this is a glycogen storage disease. Anyone postgraduates who can say what is the diagnosis in this case? Very muscular child. This is a Cocker-Debris syndrome. And last part is the skeletal one. This child has an appendicular tail and very short trunk, short limbs. And look at this dysplasia of the epiphysis, metaphysis. And this is metatrophic dystrophy. That changes with time. That changes with time. This dystrophy changes with time. And Debashish and myself published this metatrophy. Then we get another one, metatrophic dysplasia. Then Devasri, Vikram, and myself. And look at the pigmentation, chondrodysplasia punctata congenita, and this is another chondrodysplasia punctata congenita. And achondroplasia, you know, the squaring of the ileum, square, it's a square-shaped ileum, and this hypodense end of the femur. And what is most difficult is differentiating between achondroplasia and hypochondroplasia. Interestingly, hypochondroplasia has slightly mental delay, which is not in achondroplasia. And gene is different. And this is a hypochondroplasia, but looks like achondroplasia. So you need to do the genetic study. And the skeletal survey showed that there is hypochondroplasia. And then is the pseudoachondroplasia, which is again one where the face looks normal. And X-ray suggests pseudoachondroplasia. This is the family with pseudoachondroplasia, which is autosomal dominant. As I said, that metaphyseal dysplasia, look at this metaphysis. This is a metaphyseal dysplasia. And this is a multiple epiphyseal dysplasia. And it's quite painful condition, multiple epiphyseal dysplasia. All the epiphyses are being changed. And the pain and stiffness is the more important in these cases. And that's all. Thank you.